All right, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Our topic is complications of pharmaceuticals that every optometrist should know. And our speaker is my partner, Dr. Greg Caldwell. He's a graduate of the Pennsylvania College of Optometry, where he also completed a one-year residency in primary care and ocular disease at the Eye Institute there. He's a fellow of the American Academy of Optometry, a diplomate of the American Board of Optometry, and a member of the Optometric Glaucoma Society, and a member of the Optometric Wellness and Nutrition Society. He currently works in Duncansville, PA, as an ocular disease consultant. His primary clinical focus is the diagnosis and management of anterior and posterior segment ocular disease, and he's been a participant in multiple FDA investigator clinical trials. He has integrated nutrition, prevention, and wellness into his patient care, and thus he really does practice integrative optometry. He's a co-founder of Optometric Education Consultants and co-administrator of OCT Connect on Facebook. He has lectured extensively throughout the country in over 13 countries internationally. In 2010, he served as president of the Pennsylvania Optometric Association and also served on the AOA Board of Trustees from 2013 to 2016. And he's president of the Blair Clearfield Association for the Blind. Greg does a tremendous job lecturing and educating. He's got a vast array of knowledge and experience and topics to talk about. I am certainly looking forward to this. And with that, Greg, please take it away.
Thanks, Joe, and thanks for that nice introduction there. And we got a lot of complications out here to discuss. We can call them adverse drug effects. Let's just jump into it here so we can make sure we get through. As always, when we do a COPE type of or education, that we got to do disclosures here. This slide deck was independently prepared by me. There's no influence from any of these companies that are listed here. We have Allergan through Heru, Allergan down to Inova, whether I've been an advisory board or have lectured. I don't have any financial proprietary interest in any of the companies. I'm non-salaried financial affiliate with Pharmaceuticals. I also have let's see. Did you get it?
I got it.
Perfect. I sit as the PA medical director for Involved, and I do sit under credentialing and special unit investigations. It's a managed Medicaid for managed Medicaid in Pennsylvania. Healthcare registry. I do sit as the chairman for diabetes and AMD. But most importantly, the content and format of this course is presented without any commercial bias. It doesn't claim any superiority over any product or service that's out there. So, course description, optometrists use topical and oral systemic medications, pharmaceuticals to treat a variety of patients and patient care. Systemic medicines are used to treat numerous conditions by various practitioners. And these treatments or pharmaceutical agents have potential to produce ocular adverse side effects or systemic complication. And this course is just going to basically review them. So, all right. So, Joe, the first polling question,
All right, I'll get that lunch.
Just like to see if, I think this is set up as multiple choice. So, or you can enter many in. Check all that you've seen of complications. Have you seen, plaquenil toxicity, amiodarone, either whirls or optic neuropathy? Tetracycline with regarding pseudotumor or any of the other complications that we'll talk about, or ethambutol optic neuropathy. Oh, can only pick one. All right. So pick the one you've seen the most then. Thanks, Jillian. I thought I had it set up as a multiple choice. So.
And Greg, that might explain why you're in your many accolades. It's not a test item writer for national boards.
And there you go. Even though
Okay.
I did for the Board of Optometry, ABO.
Oh, you got a good amount of people. So I'm going to end the poll and share the results. Greg, are you seeing that?
Nope, nothing.
Okay. Well, hydroxychloroquine is up there, but amiodarone, the corneal whorls or neuropathy is the number one, tetracyclines, and a few people have seen ethambutol optic neuropathy and think it's all very important to know these complications. I think we've all, one way or another, probably seen at least one of these.
Perfect. Thank you
Excellent.
very much. All right. So Joe and I have a favorite neuro-ophthalmologist. Joe is the one that introduced me to Andy, and he's become a fan favorite of mine. And he has in neuro-ophthalmology and neuro-op, Andy has a few meds here, and he has the acronym HATE, the hydroxychloroquine, amiodarone, tetracycline, and ethambutol. And when he was doing his talk, I said, well, I have cases on all these. So I thought it was kind of neat. And then he has in there for erectile dysfunction, Viagra. So to start off with our first, complication of pharmaceuticals, we're going to start with the fluoroquinolones. I have an antibiotic lecture that I do, and basically I like penicillins and the macrolides and cephalosporins, and I used to have in my fourth position fluoroquinolones and sulfa. Now in the fourth position, I have sulfa and fluoroquinolones have made their way to my fifth kind of category of antibiotics for the reason of the tendon ruptures and retinal detachments that potentially can be associated with them. So with these fluoroquinolones, we're talking about Levaquin, we're talking about Cipro, that is out there. So tendon ruptures, one in 1,000. Retinal detachment, it's back and forth whether or not it exists. But we're talking tendons, and we're talking elastin and collagen, and we know that the vitreous is elastin and collagen. I think there's probably some loose association, but it's, if you want to say it's controversial, it's back and forth. Here's something that was in one of our throwaway magazines in 2018, where it's saying a total of 1,151 subjects in this case. 11,400 subjects in the control were included, and did not undergo surgery for retinal detachments. So here's one saying not associated. There's other ones out there saying associated, but let me just show you what I kind of witnessed. And I think this is a kind of a combination of both technique and maybe the fluoroquinolone, but here's dropless cataract surgery with oral fluoroquinolones being injected into the posterior pole to make it dropless. And what I'm pointing out here is we have a patient that has, an optomap here, and you can see that it doesn't look like a very myopic type of eye. It doesn't look stretched. We don't have, lattice or, paving stones. But the patient comes back, and you can see that they have, they have a retinal detachment. But, you can see that there's, maybe, big horseshoe tear here, another hole here, another one down here. Doesn't show up real well, but you can maybe see the operculum here. Here's someone that has, you can see same nerve and, kind of a nasty retinal detachment. I find retinal tears maybe once a month or maybe every other month, about 6 a year, that we send out to the retinologist to get lasered. They had the flashes and floaters. We certainly see a lot more flashes and floaters than we find. But, my point is that when you find it, it's usually just kind of little horseshoe tear. Sometimes they're big and easy to see, but sometimes they're a challenge, but you can see what has happened here. So to me, I think there's something going on, with that collagen and elastin. And this is just another patient, same thing, different patient, happened to be both left eyes. What I did is I turned on, the red free or the green free filter, whichever one this is here. And just to kind of show you how big that tear is, you can see it right here, and you can see the detachment that has occurred. So, take it for what it is. We know that the orals for sure have some type of association that's out there, but that's take it. Just wanted to point out, we know that the Cipro, if you stay up late at night, have you taken Cipro, and get a tendon rupture? Has this happened to you? We might have money for you. And it can just be after one dose. And it's kind of fun when I do this live presentation, there's always someone in the audience, or usually someone in the audience, that raises their hand and said it happened to them. So just be careful when it comes to maybe treating a sty. Maybe use it as your last line of defense, as if someone's allergic to penicillin, someone's allergic to macrolides, which would be like a Z-Pak. Someone's allergic to cephalosporins, which would be like Keflex, or the sulfa medications. It's really kind of a last line of defense that's out there. And Joe, with that being said, this one hopefully has set up as click all that applies. So the complications of tetracycline analogs that I have seen in patient care. Is it enhanced photosensitivity? Is it enhanced effects of Coumadin or digoxin? Secondary pseudotumor cerebri, or is it hyperpigmentation? Which ones have you seen? Or Joe, looks like you put into the chat box the handout. So thank you very much.
The two versions of the same handout. And if I remember, I'll probably do it a little bit later for some of the latecomers. But in the chat room are the handouts for this evening's presentation. Okay, we got a lot of people participating, Greg. We're actually doing very well. So I think I'm going to end the poll, and I'm going to share the results. And commonly was enhanced photosensitivity, secondary pseudotumor, enhanced effects of Coumadin or digoxin, and hyperpigmentation. But clearly, the number one was enhanced photosensitivity.
Great, perfect. So let's just jump in, and thanks everyone for being interactive. So, continuing with the role of antibiotics, we started off with the fluoroquinolone, staying within this. Now, we usually use doxycycline and minocycline, really not for its antibiotic type of activity. We're mainly using it, say, for the anti-inflammatory, the steroid approach. At the low dose, it's anti-inflammatory. At the high dose, let's say 100 milligrams twice a day, we'd be treating maybe Lyme disease with that, or maybe some MRSA infection. But like at 25 milligrams or 50 milligrams once a day, we're using it for its anti-inflammatory and maybe keeping people on chronic. So, this little cartoon reminds us that maybe you should try a little sunscreen the next time. It was kind of a cute way to remember the photosensitivity. In the oral form, for sure, we want to make sure that we avoid in children. The chelating side of it can stain those teeth that's there. It's a category D. It's kind of nice to remember using the old system that was out before 2015. Doxycycline, pregnancy category D. You just want to avoid in pregnancy and breastfeeding women. I lecture with a pharmacist, Dr. Tracy Offerdahl, and she kind of reminds me, if a patient is on Coumadin, basically just about everything will affect Coumadin. So just be careful with anything. And so really, with that being said, there's no surprise that doxycycline or minocycline can affect the Coumadin levels, and then digoxin. Now, I don't put those in there as a reason not to prescribe these medications. I didn't say that they're contraindications. I just said that they're side effects. Just means we have to be a little bit, pick up. It's going to take a little time for this patient. Call up maybe the internist that's prescribing, or the heart doctor that's prescribing the digoxin, cardiologist, and explain to them. Those calls usually go something like, hey, cardiologist, this is Greg. I'm the optometrist, and I got your patient on digoxin here, and I'm going to put them on doxycycline. And they're like, oh yeah, they'll be off of it in a couple of days. It's not going to affect their dig levels, their digoxin levels. That you could say, and that's why I'm calling. This patient's got this kind of skin problem, just like dermatologists use it for all the time. They got this meibomian gland dysfunction, and real quickly they go, okay, now I get what you're calling about. Yeah, just thanks for calling. Send me another quick note, but I'll make a note in their chart to get their dig levels checked. So same thing happens with Coumadin. It's the same kind of conversation. Whoever you're having that with, they'll get their, their clotting times checked, a couple of weeks after, and then they'll start adjusting up or down. One of the other side effects of using this medication, I used to call it idiopathic intracranial hypertension, and it was kind of neat one night. And, Joe said, "Hey, what causes swollen nerve heads?" And as you know, Joe's, one of his expertise is in ophthalmology, neurooptometry, definitely the neuro side. And I told him about this case, and he said, "Oh, what caused it?" And I said, "Digoxin." And he goes, "What's that called?" And I said, "Idiopathic intracranial hypertension." And kind of went back and forth for about 5 minutes until I figured out, like, okay, we shouldn't be calling this maybe idiopathic. And it's true, because how could it be idiopathic if we know what's causing it, right? So it's the doxycycline or the minocycline, and then the hyperpigmentation that can occur. So, this is an old case. This is from 2010, but, I have, as Joe mentioned, I'm in private practice. We have in Duncansville, we have 5 optometrists in the practice, but I'm only working 3 days. My wife's working 3 days. We have a senior partner kind of working 3 days. Got a couple guys working 5 days. With that being said, we probably have about 3 to 3.5 full-time equivalent optometrists. And with that being said, we see this, one of us see this probably once a quarter. So here's a patient that comes in and they have bilateral swollen nerve heads, and it could be that proverbial, 5 o'clock on a Friday that's out there. And you have this person that comes in and they're on minocycline and doxycycline. And usually one of the questions I get is, when I do this live, like, well, it's probably from the minocycline, or it's probably from, that. Bilateral swollen nerve heads, do I have to get this person worked up for that bilateral swollen nerve heads? And in this case, it'd be an MRI and an MRV that we want to do for this patient. And the answer is yes. And, this kind of still, Joe's words, when I've asked him, the first couple of times that this happened to me, he goes, "Well, Greg, that's correct. It probably is from the tetracycline. But, people that have swollen nerve heads from tetracycline can also have, a brain tumor or some type of venous sinus thrombosis. So you might be, even though you're a betting guy, maybe in this case that it's tetracycline, it might be worth imaging these patients and getting it done."
Greg, that's that is a great point. We look at something and we jump to what we think is the obvious answer, and we try to have that Dr. House moment, but there is no single test that will say, yes, this disc edema is due to the medication. It becomes a diagnosis of exclusion. And we should never put a diagnosis of exclusion as our first diagnosis. It should be our last diagnosis.
Perfect. Yeah. Thanks, Joe. So here's a patient. Again, this turned out to be from doxycycline. This turned out to be from or minocycline, one of the tetracycline analogs. You could see the bilateral swollen nerve heads. We did image them up. This one was back in 2010. I did use Joe's phone a friend at that time. A lot of times people ask me, like, what's the timeline? So you could see here was, August 19th. And this was the original. We had the patient image, we said, yeah, it's probably from the doxycycline, called the physician that started it. They immediately discontinued. So the nice thing was, as I just said, can you have the patient come back and follow the patient closely? And you could see 12 days later, you could see the amount of swelling has already started to decrease, maybe a little bit more obvious in the right eye than in the left eye. But again, the timeline, 25 days later, that right eye looks pretty darn good. The left eye is definitely improved, but still has some swelling. But you could see by day 48, pretty much all the swelling has disappeared. And Yeah, you could use OCT, and that's a whole other lecture that we could put on about how to use an OCT to tell whether it's pseudoedema or true edema that's out there. But you can see in 48 days, it pretty much returned back to normal here. So remember that, doxycycline, and that's one of Dr. Lee's hate medications that's out there, the T and tetracycline. We don't really use tetracycline, but the analogs of doxycycline and minocycline that's out there. And this is really a slide. This is a white slide here that kind of depicts what Joe was telling me about pseudotumor versus idiopathic intracranial hypertension. So, Joe, I think with you here, when you're not here and I'm doing a lecture, I can walk through it, but I think you're the expert in this arena. So do you want to walk through this slide right here?
Sure, Greg. I'd be delighted to. People think that pseudotumor is an old term, and that the current term is IIH, or idiopathic increased intracranial hypertension. And it's not really true. If you ask me what is the best term to use, it is still pseudotumor. Pseudotumor means there is no tumor, but there's increased intracranial pressure. But as Greg's pointed out, there are things that have been identified: venous sinus thrombosis, medications, exogenous causes, hypervitaminosis A, oral contraceptives. There are a number of things that have caused it. There's no tumor, but there's increased intracranial pressure. And in that situation, really, it's going to be called secondary pseudotumor. Now, you may have increased intracranial pressure, no mass lesion, no other neurologic deficits, maybe except for sixth nerve palsy. And there is no exogenous medication or exogenous agent use, and there's no venous sinus thrombosis. And typically, this is the younger female who might be a little bit overweight. And this is what we call idiopathic intracranial hypertension, and we call it primary pseudotumor. So pseudotumor is still a good term. IIH should only be used when there's no other potential cause there. It's not a bad term. It's not the newest term or the better term. It just is a different term, really kind of meaning a subset of the same thing, though. I hope that was clear for everybody.
Thanks, Joe. And, so the key is, I think to kind of sum it up, and that's what Joe was driving home with me. If we know what it's coming from, we really don't have to call it idiopathic. It's more of a secondary type of approach. So, all right. So, again, I see these probably once a quarter in our practice, which we have about 3 to 3.5 full-time equivalent optometrists. And when I do, I usually try and take the pictures and put it on ODs on Facebook. Dr. Alan Glazer's asked, Joe and I to kind of hop on there and make comments from time to time. And, here's a patient here, and you can kind of see the nerve is swollen, and we figured out. And, each one of these, they're bilateral swollen nerve heads. And, Joe, is just to kind of confirm, and, if you want to talk a little bit, MRI, MRV is kind of the initial workup. I really don't lead them into doing lumbar punctures. We usually kind of have it figured out. I guess, if it doesn't start to come down reasonably, maybe we could tap it and maybe there's some other infection. But is that a good thought process? MRI, MRV, and
yes,
hold off on that puncture?
Whenever we're dealing with bilateral disc edema and we've got a clinical suspicion of papilledema, we may ourselves, or the individual clinician listening, to our lecture, may not order the imaging herself or himself, but we're going to be involved in at least helping somebody other physicians do it. But they need to help. An ER physician doesn't know what to do necessarily, and neurology and ophthalmology are not always at hand. So it really requires an MRI with and without contrast of the brain, and we also need an MRV. And we tell them, MRV looking for venous sinus and transverse sinus thrombosis. MRV looking for hydrocephalus, intracranial mass lesion, intracranial bleed. And if you want to get fancy, tell them to look for cella turcica emptiness and looking at flattening of the globe. And those are two things, the empty sella and the flattening of the globe are very characteristic of increased intracranial pressure. If there's nothing else going along, say for a sixth nerve palsy, there's no evidence of infection. A lot of times the lumbar puncture will not be done, but you do need an contrast-enhanced MRI and an MRV. And if you're going to be sending these patients to another physician or an emergency room, help them out. I always tell them what to look for, and the reason for MRV is it's magnetic resonance venography. We're looking for a pacification and blockage and thrombosis of the venous sinus and transverse sinus. So that's where we have to look at that, and that may not be readily apparent. And if you have venous sinus thrombosis, you're dealing with a coagulopathy and a thrombophilic disorder. And that's we all work together. And when I send patients like this to the emergency room, I also send my cell phone so that the ER physician and the hospitalist can contact me, and I will tell them that they do contact you.
And thank you, Joe, for that. That's obviously in depth and exactly what we need to remember. Even though we believe this is from tetracycline, people can have other things going on. So, and this is just the other eye. You can see here that the swelling around the nerve head stopped the medication, and over time the patient slowly improved. And there they are there just again. This was an, OMG moment here. I walk in and said, "Hey, Doris, how you doing today?" And she's doing great. And I said, "Anything new?" And she goes, "Well, yeah, there's something new." And she pulls up her pant leg here and she goes, "I got this stuff happening to my legs. It doesn't really hurt, not really having any problem. Went to my doc. No one can really figure out what the heck this is. They did a biopsy on it, so on and so forth." And so she's like, "Yeah, other than that, everything's going great, Doc. My eyes are fine." And I just went like this. And she goes, "Doc, why did you do this?" And I said, "Well, this is what I caused this for you." I said, "I'm treating your meibomian gland dysfunction." And so remember when I told you about that pigmentation? She goes, "This pigmentation?" She goes, "I thought it'd be like something a lot milder." So basically, I always encourage docs that take this course or whatever, you can go to Google and type 2 words, type minocycline or doxycycline, pick whichever one you want. And then the second word being hyperpigmentation, those 2 words, hit enter, click on images, and you'll see all kinds of pigmentations that can occur from all over the body. So we were able to identify this and basically had her stop. And you can see here, over time, she did fade, and you can see there's what she looked like originally there. And so that's that. And here she is a year later, and you could see that she still faded, but still had some pigmentation going on. You can see going from, back to the beginning. So she was on, when I do this live, usually the questions I get is, how long was she on this medication? She was on it, I would say, about 9 months, maybe 11 at max. When you read the literature, it's usually a little bit longer that the patients are on there before kind of getting this kind of pigmentation. The pigmentations can be permanent. It could be on the face, can be really anywhere on the body. She went through cancer treatment, had some chemotherapy. So that's usually the thought process of maybe why it came on so quickly, if you want to say, being 9 or 11 months, which is a little bit, usually they're on doxycycline and minocycline for longer than a year. So,
great.
So
Does it ever completely resolve?
Well, the answer is yes and no. I see that question that came in. Okay. The answer is, does it completely ever resolve? When you read the literature, it just says it can be permanent. And this lady here, you can see here, if you want to call it, can be permanent. She still to this day has a little bit of pigmentation changes. It certainly has continued to fade some more. So I would call that permanent for her. But then I've had patients that have come in, every time someone's on doxycycline or minocycline, what happens is that I always tell them about the pigmentations that can occur. And a couple of times patients have come in and said, hey, doc, look at my fingers here. Is this what you're talking about? My fingernails, or pulled up some pigment? That's exactly it. And I've seen those fade 100%. So it can be permanent. I think permanent means it will fade, but not go away 100%. And I've seen it go away 100%. All right. So there it is. How long was she on it? And then great idea about giving your cell phone number. Hey, Joe, mute for a second there. I think we're picking up your fan above you. Yep, that was it. So, all right. So that's kind of the antibiotics. We really don't use doxycycline maybe for the antibiotic side of it, but we use it maybe for the antiviral, but it falls into for the anti-inflammatory. So antivirals, let's jump into there. Besides dosing, what's the difference about the oral antivirals? This was from the herpetic eye disease study. There was the heads 1, heads 2. The main reason why people stopped dropped out of the head study was GI side effects and rash. Many patients on the oral acyclovir had GI symptoms. So whenever you look at these medications, here is, you can see Zovirax or Acyclovir, here's Valtrex, here's Famciclovir. If you look really closely right here, and I'm going to highlight it, you can see in this one and in Famciclovir, they both have lactose. So I like using Valtrex for this reason. Valtrex is a prodrug of Acyclovir. You can kind of see it in the name. It says Valacyclovir. It has Acyclovir in it, but the nice thing is the formulations and all the generics, none of them have lactose. So for that reason, a little bit better dosing if you want to say 1,000 milligrams 3 times a day, as opposed to 800 milligrams 5 times a day. Being that it has, it's free of lactose, that's usually my drug of choice when going towards treating someone with herpes. Now, when it comes to Acyclovir, Valacyclovir, and Famciclovir, how about CNS? Kind of this Charles Bonnet-like syndrome that's out there, this agitation, kind of more like release hallucinations, not this irritative type, and confusion. The best one for that is Famciclovir that's out there. So you can Famciclovir. I never really had to change anyone over to Famciclovir, but I can tell you I had this patient gets transferred up from Pittsburgh area. She's getting a little bit older. She had to move from her house. She's moving in with her daughter, needed someone to follow her for this bilateral cornea transplants from herpes simplex, and they still had her on 1,000 milligrams 3 times a day. Boy, she couldn't have been more than 97 pounds wet with clothes on. And she kind of had these Charles Bonnet kind of hallucinations, a little bit agitated, little confused, not bad, maybe kind of dementia-like. I'm not really the expert in that arena, but it's just confusion. And so we started backing her off of her her Valtrex. We got her down to 1,000 milligrams once a day, and we've seen that confusion and hallucinations and agitations kind of disappear. So remember, these medications are very safe, but again, that's why we're here tonight. They do create some adverse drug effects. So this one here was put in. I do this with Tracy Offerdahl. She's a PharmD. She usually talks about this. She's just talking about this oral antifungal, and it's V-Fend. I'm not going to speak too much about it. She usually is the one to talk about it, but I kept it in here for tonight just for reference for anyone that's out there. You see anyone taking this, that they can have blurred vision, color vision changes, optic neuritis, papilledema, photophobia, can resolve in about 60 minutes after taking the dose. So just be aware of that one out there. I really don't have any clinical, I usually like to put things, as you could see, and take pictures of things, but it's just in here for more FYI and education. When we're going to move into this category here, we're going to talk about the alpha-1 blockers. Alpha-1 blockers, like probably the well-known one here, as you can see, is Flomax. and it can create a floppy iris syndrome. You also, within that category, you can see Coreg. I do see people still coming in on Coreg or Hytrin. These are alpha-1 blockers. This is really the category of medications that gives us our Upneek all those side effects, because they play, once they're labeled an alpha-1 blocker, or I'm sorry, an alpha-1 agonist or antagonist, this is how you start getting all of your kind of side effects from these medications when it comes to the topical medications. But you can see here, floppy iris syndrome is a big one here. This is a patient that, at times, they're on this medication. It creates the floppy iris, the flaccid part to the iris. The miosis can occur from that. And then, after 4 rounds of tropicamide and cyclopentolate, they still dilate poorly. And this is important for a couple of reasons at the time of cataract surgery. One of the worst things that can happen at cataract surgery for a surgeon, and that's why they dilate people when they see them for their consultation. They like that pupil to be as big as it can be, so they can make that capsulorhexis. So if they can't dilate, then they'll use iris hooks. At that time, they're probably using a little bit more viscoelastic. And so, you got to, be careful, because on day 1, the patient comes in and has an IOP of 43. And so they have an IOP of 43, and I've gotten used to, burping a paracentesis. You know where the main wound is, about 90 degrees away. A lot of times I'll ask the surgeon, are you right-handed or left-handed? Or I can pick it up after doing their post-ops, because you can tell where the incision is 90 degrees away, whether they sit at the head of the patient or off to the side. You can find that paracentesis and you can burp it. Well, I can remember going back about maybe 8 or 9 years now, forgetting to look that this patient was at high risk, floppy iris, on this type of medication, Flomax, burped the paracentesis, pressure came down nicely, also got some iris right into that nice paracentesis, had to call the surgeon up and have them push that iris back into place. So just be aware that that's out there, and just be careful. Joe, do you have a comment?
Yeah, I've got a question. Greg, not everybody will or feels comfortable burping a wound. I know my wife did one not too long ago, and the patient went into a vasovagal syncope. And I think it was the last time she's ever going to do that again. Have you ever had any issues where it didn't come down medically? Because, we occasionally get this situation and, the pressure is above 50. And the key that I see is when I see microcystic central edema, I know the pressure's high, regardless of what my technicians say. But, two Diamox, in the office, 2 more tonight, 2 more tomorrow, see you in the morning, here's a bottle of Cambigan or a couple vials of Cosopt PF. And by next day, we're back down to 17. I've never had any issues with that. Have you? Where that didn't work?
Yeah, that was kind of what I did a lot. I don't have as many complications, I guess, or the issues, people passing out, and I just be caution if the patient has been on has a floppy iris, to whether to burp it. And in that case, I would probably, my favorite thing to do is just give them Combigan and have them use it 4 times a day and see them back the next day. And maybe avoiding the Diamox. Certainly it's a safe medication, but it's just a nice quick way to kind of bring it down. Kind of another little tidbit out there, guys, doing post-ops. When you see the Joe mentioned about the edema, if it's clear if it's swollen in the center but clear at the edges, that's usually because of the phaco. They bring the lens up into the anterior chamber, trying to save that capsule and trying to keep that capsule intact, and they phacoed the lens. If you see it 360 from limbus to limbus, it's usually the pressure is going to be high. So if you see that central edema and they have a clear zone and the pressure's good, that's just usually phacoedema. But if it's diffuse edema, then it's usually, from limbus to limbus, you can pretty much guarantee that IOP is going to be high. That's out there. So let me see some of these questions that are
yeah,
rolling
there are two. I think the one we didn't get to is children dosing with antivirals.
Yeah, how do you dose children based on weight with antivirals? Yeah, you can dose it on weight. One of the best ways that I do is if the patient, if the child is gone through puberty, like the other day, I had this 13-year-old boy come in. I was going to use an antiviral. He was bigger than me and lifted weights, and he was through puberty. So puberty is kind of the key here. If they're through puberty, if they're not, then you could just go by the recommendation of the kilograms, milligrams per kilogram, per child. And you can find all that stuff on the internet. Or what I'll tell you to do is phone your pharmacy friend, and they'll be more than happy to help you with the dosage, and then you can put it right into your electronic health record. That's out there. So that's
one thing you can also do, and I hate to say this, but it's what everybody else does. You can Google it. Excuse yourself, go out, take your phone, Google it, and Google at least two different sites to make sure it's consistent, and then you're good to go.
Yeah.
If you
the issue is when you do that is that sometimes, let's say it came down to some crazy number and you send it to the pharmacist, then they call you and say, okay, we don't have it in that milligram. Do you want to go a little bit higher, a little bit less? So that's, so just be aware of that. And so, but yeah, that is, you could Google it and see which is the best way to go. Can you quickly explain the mechanism of high IOP, the situation, alpha blocker, viscoelastin, iris hooks? Yeah, I can do that. The whole idea is, it's a trick that the surgeon uses, right? So when they go into surgery, they know the patient is on Flomax or any of these alpha-1 blockers. So they know that iris is flaccid. Just like I created that iris to come through that wound, you can, when the surgeon does surgery and they make a larger incision, that wound can come out. And that's why you'll see some of those, kind of rough looking irises, even in the most skilled surgeon, because, all of a sudden that iris wants to start coming out that port. And what they do is they use a lot of viscoelastic to kind of keep everything in place, right? More than they would on a normal iris. So what happens is the next day, that they can't get all the viscoelastic out. So it just causes the trabecular meshwork to kind of get gunked up. And then the next day they have a higher pressure. So the iris hooks are just used to kind of open up that pupil because of the meiosis. So great questions that are out there. And thanks for making it interactive that way. Joe, let's do the next polling question here. The question is, I have seen cornea verticillata cause vision loss. I know that a lot of people have seen it. Have you seen it out there that causes vision loss?
All right, the people are off and running.
Julia has reported no. So again, guys, thanks for keeping this, interactive. You can certainly put questions, as you guys been doing, or answers into the chat box.
Okay, we're doing really well with the responses. Got it pretty high, but it looks like everybody has actually stopped. So I'm gonna end the poll and share the results. And 83% have not seen verticillata cause vision loss. 14% did, and 3% believes it doesn't cause vision loss.
Perfect. So let's jump in here. And, when we're talking about, amiodarone, it's usually used for an anti-arrhythmic medication. Cortisone or Cardarone is also a very well-known, trade name that's out there. Amiodarone is generic, creating those corneal deposits. And then an optic neuritis. And if you remember, that's one of Dr. Lee's, one of his hate medications that A in hate is amiodarone that's out there. And here's a case right here of amiodarone toxicity. Now, there are stages, grade 1, 2, 3, and 4, and you can see punctate opacities, more aligned, so on and so forth, increased number of branching patterns. I can tell you that when you start getting into 3 and 4, there's that potential out there of that vision loss that's out there. And let me just kind of cut to the chase. You know, the vision loss is from irregular astigmatism. Remember, the cornea is about 44 diopters. The total power of the eye is 60. So 2/3 of the power of the cornea, 2/3 of the power of the eye comes from the cornea. So here's a patient that over the last 6 or 9 months, especially at near, is complaining a decrease of vision. Their vision best corrected was 20/50. So let me just show you a topography here, and a topography of this is a technology that allows us to see the posterior float and the anterior float. It does optic section, so it gives us a pachymetry. But if you look at this keratometric float right here, you could see here that doesn't look too irregular. It looks steep, but it doesn't look too bad. So we take a little closer look here at the other eye, and you can see the posterior float and the anterior float. It doesn't really look like it's keratoconus, but we can see here that we have, again, it doesn't look, you know, too bad, but pretty steep, little bit of irregularity going on. So what I was able to do for this patient to kind of tell you how I solved it is I really keep 2 RGPs at the lens. One is a 44 diopter plano. The other one is a 39 diopter plano lens. And this one here, as you can see, the mean in the center here is about 43, 46. So I take the 44 plano, put it on the patient's eye, and the acuity got, you know, a little bit better on this patient, quite significantly, able to get down to about 20/25. So we called the cardiologist, or I called the cardiologist up here, and basically said to the patient, I said, look, or said to the cardiologist, look, this patient is having vision loss. And, you know, I'm not sure if the cardiologist used the proverbial, well, you're just an optometrist type of thing, or however it went. But finally, I was able to get the topographies over, get the cardiologist convinced that the vision loss was coming from this irregular astigmatism, stop the medication. We know that when it's in the cornea, it is reversible. And 6 months later, you can see here how the cornea now looks a lot smoother and a lot more normal rather than irregular. And I think I put them side by side here for you to see. And if I can just get my computer to work here, I'll get you to see it right there. So right there they are side by side. The one on the left is, you know, after discontinuing, you could see, you know, 43.5 down to basically 42.8. Nice regular. You could see what has happened here. The patient did have some irregular astigmatism. Same thing happened here with the left eye. You can see where it was 6 months before. This is just recently. The visual acuity approved at 2025. It was still reduced from a little bit of cataract, but I think we don't pay attention to the vision loss or the irregularity that's out there. I usually get a corneal topography on all patients that are on amiodarone. The reason being is I would like to be able over time see if it's changing. And I've probably have worked with cardiologists more over the last few years and discontinuing or switching to a different type of anti-arrhythmic medication for the patients based on this. This cardiologist that's in town here, he is a lecturer, and he does take this to his conferences and demystifies the myth, I guess, that's out there of, hey, look, amiodarone can cause vision loss when it's in the cornea. And he uses these cases and I've sent him a couple other ones that he uses to teach his cardiology friends. Now, with that being said, you know, we talked about it in neuro. as being one of those hate medications. Here's a 67-year-old man who complains of slowly deteriorating vision over the past 8 months. And he has a history of it's kind of sketchy how it all came about, but he has a non-arteritic ischemic optic neuropathy, sees the family physician, diagnosed him with, or he was told they had a non-arteritic, hasn't seen the PCP, some way, somehow, they tagged the non-arteritic and through some testing to some type of maybe arrhythmia, but the patient ended up on Cardarone. And you could see here, the vision was 20/80 in that eye before that was the non-arteritic eye in 2025, 9 months ago. They come into the office and they're like, hey, Greg, we've been to a bunch of places. They can't really figure out what's going on. They think it's some neuropathy, but patient is 2,400, 2,200 and, doing some very constricted confrontation fields, vortex whirls. Here are the visual fields. And one of the things I like to teach, visual field of a blind eye is about minus 32. This patient comes in and they're minus 28 and minus 30.59 here. You can see that these are some pretty significantly involved visual fields. And so I mentioned to him, I said, look, it's rare, but you'd have all the testing done. I think this is, a side effect of amiodarone optic neuropathy, one of those, the A in Dr. Lee's medication. You can, or in his list of his hate medications, and you can see here the optic nerves just not looking, very pink and healthy. Sent this patient down to Wilmer, and because they wanted to have a third opinion, I guess, just to kind of a second opinion on the amiodarone. They tested the patient and made it a diagnosis of exclusion to where this patient had amiodarone optic neuropathy that's out there. So, Joe, I know this is kind of like your kind of expertise that's out there. Do you have any comments on amiodarone toxic optic neuropathy?
I think you covered it. You covered it very well. It's the importance of identifying it, and I'm going to share a story with the audience and remind you, because I know you were there. But at one of our live conferences, we had two really phenomenal neuro-ophthalmologists, Nancy Newman and Valerie Buse, and they presented a case where a patient was losing vision, very, very similar to what you had. And the optometrist did the examination, but was not complete on the medication history, and didn't get out the patient was using a form of amiodarone. Then referred to an ophthalmologist, and the ophthalmologist really just took the optometrist information and didn't do a medical history by themselves. And it couldn't, then referred to a neurologist, and the neurologist did a better medical history and saw the patient was using something called Pacerone, which is a brand name of amiodarone. But unfortunately, that neurologist didn't recognize that it could cause optic neuropathy. So it was an unfortunate case where a few people had made some mistakes, and a patient went blind from this medication.
So, thanks, Joe, for that. So just a reminder to everyone that, in this case here, that, we see corneal whorls all the time. And so just a reminder that these corneal whorls, as depicted in this picture here, can create irregular astigmatism. And, the course of my lifetime, like I said, I've mentioned that we've worked with cardiologists and switched medications because of the irregular astigmatism. Do I see patients 2020 going to 2025 from this? Yes. Do I have them switch? No. But this patient went from, is down to 20/50 vision, had a few other symptoms. So that was one. And those are the other ones that are out there. So I guess you could maybe call that a category 4, if you want to say that, somewhere 3 or 4 causing that. So just be aware that it's not as benign as we make it out to be, even on the cornea side. And then luckily on the optic nerve side, it's a lot rare. But, I've probably had 2 cases of amiodarone optic neuropathy in my course of, say, 27 years, and this happened to be one of them.
Greg, there's a really good question came in. Would an OCT of the ganglion cell layer show a dropout? And I would say yes. But now you're dealing with a patient who comes in who's got vision loss, you've got bilateral field loss, and perhaps optic nerve pallor. It will show that, but it doesn't give us the diagnosis. It's the important thing of recognizing toxicity, that not everything is a brain tumor, but it should. Maybe even the nerve fiber layer would be diminished there.
Yeah, I would say definitely first would be the ganglion cells would drop out. And then I would say over time, you'd probably see atrophy of that nerve fiber layer. I agree. This again is just another one that, Dr. Offerdahl had plugs in when we do the lecture together. And you can see it's an anti-arrhythmic, digoxin toxicity here due to the super threshold levels, this yellow-green vision, blurred vision, and halos around objects. So, we talked about earlier that tetracycline the tetracycline analogs can enhance digoxin, but here digoxin can create some yellow-green blurred vision and halos around objects. So, Joe, with that being said, let's maybe launch polling question number 4. Just question out there, just seeing who's used the netarsudil products. The trade names of those would be Rhopressa, Rocklatan, in their treatment of glaucoma. Just kind of seeing, those who treat glaucoma or those that are out there. Have you used it? Have you seen some of the side effects that's out there? And it looks like we're caught up on the
questions. Yeah.
Yep.
But when dealing with optic neuropathies and toxicities, when you have something that is bilateral, we have to always consider the metabolic diseases, the nutritional deficiencies, and the toxicities.
That's a good way of putting it. So, yep. Good summary.
Okay, people have weighed in nicely. Looks like we're beginning to slow down a little bit, so I'm going to end the poll and share the results. And it has said, I have used netarsudil, Rocklatan, Rhopressa in my treatment. The majority have said no. About 3/4 said no, and 1/4 said yes.
Okay. So let's just talk about it. So, Rhopressa and Rocklatan, they're a netarsudil product. It's by Aerie Pharmaceuticals, approved in 2017. Treatment of glaucoma and ocular hypertension. A little bit different of a mechanism here. It's a Rho kinase inhibitor, ROCK-NET inhibitor, used once daily in the evening. But it did come up with some new side effects here. Conjunctival hemorrhaging, probably that's what it is. That's what they have on the package insert. I think it's a little bit more vasodilation. This verticillata came out, and I think conjunctival hyperemia, we're used to that with the prostaglandin analogs. Just want to talk briefly about it. That's why I put the polling question in there. 75% have not used it, 25% have. A very low concentration targeted for the disease of glaucoma. The glaucoma is a disease of outflow. The trabecular meshwork usually becomes stiffened. We're trying to get that fluid through the trabecular meshwork into Schlem's canal. And what Dr. Epstein did with this medication was to try and find something that worked on the actin and myosin. And you can see here, nothing trickery with these photos, is that they're using the same magnification to show how the trabecular meshwork expands here. And I can tell you, I'm all about trying to give people clinical pearls when I do my lectures. I'm a clinician myself. I just try to take the science that's out there, apply it, and then bring some clinical pearls to the audience. I can tell you that this medication, as you can see here, will lower an IOP anywhere about 4 or 5 millimeters of mercury. Sometimes it's a little bit less. Sometimes it's a little bit more. 4 to 5 millimeters of mercury. So if you have a patient of 28 and you get 5 down, okay, 23 doesn't sound real great. But if you have someone that's 18 and you're trying to get them down just a point or two to your target pressure, 12 and 13 sounds pretty good. So it's pretty steady on how it lowers the IOP. If it's a 30 or if it's a 25 or it's a 15, I've seen some 15s go to, to 10s and even below 10, and even sometimes lower than that episcleral venous pressure, just for the fact that this medication has been shown to be able to lower on the episcleral venous pressure side. So Rhopressa has no labeled contraindications, very safe medication. During the study, timolol, because it's an inferiority study, did what it's supposed to do. It changes the blood pressure and the heart rate, but Rhopressa didn't have any of those side effects. So being a complication, we're pretty well systemically, pretty much all the side effects come within the eye where we're using it, the kind of the target organ. They labeled these, maybe there is some subconj hemorrhage in this picture, but I think maybe it's from the vasodilation. Remember, this medication can lower the episcleral venous side. So if you remember, ciliary body, through the pupil, anterior chamber, trabecular meshwork, Slem's canal, collector channel, episcleral venous, eventually into that cavernous sinus area, the superior orbital vein, and then how it drains. Joe, is it the cavernous sinus? Is that where that superior orbital vein goes, or where does that go after that?
Superior and inferior orbital vein drain to the cavernous sinus, and that's going to go out through the inferior petrosal sinuses into the jugular vein.
So that's why if you get a cavernous sinus fistula, you can get the buildup, the blood back in there, almost kind of what it looks like maybe right here. But this is vasodilation in a sense from this medication where they're calling it conjunctival hemorrhage. It's the same pathophysiology as amiodarone. It's a phospholipidosis that creates this buildup. So you can see here's the control that's happening in the cornea. Here we go with the amiodarone and the netarsudil creating the kind of that verticillata that we talked about. Now, this is right from the ARI MSLs, the medical science liaison, showing the verticillata, kind of how it looks like when you take oral amiodarone. But let me show you my case here. I remember seeing this case. I'm using this unilateral. There's something, I forget why it was only in one eye. But here's the patient, and I'm seeing the patient. Hey, everything's going, using your drops. Yeah, pressure looks great. Awesome. I'm all excited. Pull the microscope over, and I'm looking at it going, and the picture maybe doesn't do it justice. It's kind of all throughout this cornea. You could see this pigmentation. And I'm sitting there going, where's all this pigmentation coming from, right? So I'm starting to think like Fabry's disease. Maybe I got something really cool here. Starting to think the zebras. And I look at the other eye and I come back because I'm thinking it's going to look like the traditional, verticillata that comes in orally. Remember, we're using this topically. And that's what I've seen, is that it's not that traditional. That's my clinical pearl in this case here, this slides, is that it's not that typical kind of a third up, 2/3 down. And I remember literally laughing out loud, and the patient's like, doc, what the heck are you laughing at? And I said, you know what? I teach this complications course, And I literally took me about, 2 minutes here to kind of wrestle in my brain back and forth, going back and forth, figuring out what this is. And it's really that side effect that, we were taught in the ARI slide deck about, verticillata being 20.9% is one of the adverse events. You can see the hyperemia is about 54%. That conjunctival hemorrhaging or vasodilation is 17%. And that 1 in 5 patients will get the verticillata. The nice thing is, I chatted with the medical science liaison recently. No one has reported that irregular stigmatism in a sense, or that vision loss. Maybe if we do topographies, we'd pick up on the irregular stigmatism, but there's really been no one reported that had the vision loss, at least to the MSL. And then I can tell you that I stopped it on a few patients, and it does reverse over time. That's out there. So sticking within the glaucoma realm here, these are drugs that cause angle closure glaucoma. And Joe, if you want to, these are your slides, and you have one down here kind of underlined and highlighted. I can kind of click through the slides here as you tell me when to click. And this is out of your, this is, you shared this case. So I think you should go through this.
Yeah, there are a number of medications can actually cause angle closure glaucoma, and it's often sort of like an allergic response causing a congestion in the ciliary body. And ironically enough, one of them is actually acetazolamide, Diamox. And we use Diamox to treat angle closure. And ironically enough, it can be actually one of the medicines that can cause angle closure. But out of all of these, the one we have to be aware of is something called Topamax or topiramate. That's actually an anti-seizure medicine that has probably more off-label uses than it has on-label uses. It has been used for headache. It has been used for mood disorders. It has been used to reduce the psychological dependency on alcohol. It has been used for weight loss. And one of the things that it can certainly do is actually cause angle closure. I guess you can advance. And what is happening is there is probably a sulfa-allergic response or sulfa-sensitive response that causes a swelling and anterior rotation of the ciliary body. Now, when this happens, it reduces tension on the zonules that leads to a lens thickening, and it induces some myopia. When I say some myopia, I mean several diopters. And that is usually the concern the patient presents with, that their vision has suddenly changed. So this is going to change the refractive error. A person who might be hyperopic may become myopic, or someone who's emmetropic could become 4, 6, or 8 diopters myopic. And this leads to a shallowing of the anterior chamber, which is the angle closure mechanism here. Greg, next one.
Oh, hold on. There you go.
I think this is just a nice diagram of what's happening. You can see the ciliary body and the iris and the diaphragm there, and everything is fine, but they undergo this really exaggerated response. You can see on the right, a huge amount of vasodilatation, not unlike what you might see in a scleritis. And that ciliary body and that uveal tissue really becomes a blood swamp. And as it expands, it actually flattens the chamber and closes the angle. Now, there's no pupil block here. Aqueous can get from the posterior to the anterior chamber, but it's stuck in there. Go ahead, Greg. And this is the key difference is you don't have a pupil block angle closure. You don't have iris bombé. You actually have a shallowing and collapse of the chamber, which is not only at the limbus where the angle is, but even centrally, you can certainly see how really narrow and really shallow that anterior chamber is. Yeah, that iris is not convex. It's not bowed forward. It's not an iris bombé. It's just a flattened chamber. Next one, Greg. And a nice case to illustrate a 39-year-old female who had been started on Topamax for migraine. And the key here is it is not a buildup of medicine. It is usually rapid. If a person's been on the medicine for over a month, they're not going to have an issue on this. It is often just one dose, 1 or 2 doses. Or I have heard of a situation where the patient was on it, the dose got doubled, and they underwent this situation. But she presents suddenly with blurred vision and some mild eye pain. The vision blur was really more significant for her. She just felt a pressure sensation. Now she's about a 6 diopter myope, and her pressure is 44. Craig, next one. So, polling question, what is the best management? Is it cycloplegic and topical steroids, oral Diamox, Cosop and Lumigan, immediate LPI, or I'm not sure, that's why I'm here. So I'm going to launch that poll question. And what do you think? We got a person with pressure of 44. She's on Topamax. What are we going to do about this? Is it cycloplegia and steroids? Is it Diamox? Is it Cosop and Lumigan? Do we put a hole in the iris, or Yeah, a reasonable answer is, I'm not sure. That's why I came to this course.
You know, Joe, it's kind of neat. I always try to tell the audience like how many times I see this or our practice sees it throughout the year. This is probably in that, that 3 to 3.5 full-time equivalent. We're seeing it, say once every 6 months, once every half a year. We did have one already this year. So this is like a 2 or 3 times a year type of finding. So we do get a lot of referrals for urgencies from the primary care docs, and it might put us a little bit higher, but just FYI.
Okay, our responses are beginning to slow down, so I'm going to show the results. Oral Diamox. I'm sorry, I'm not sure that's why I'm here. That's okay. This is actually fairly complicated. Some people said immediate LPI. Some people said some topical glaucoma medicines, an oral medicine, and we have in there cycloplegia and topical steroids. And actually the answer is, or the best answer is the first, cycloplegic and topical steroids. Now, obviously, if we can stop the medicine, that's going to be helpful. Now, if the patient's using it for seizure, I'm a little hesitant to do that without contacting the prescribing physician. But if they're using it for weight loss or headache, I would not hesitate and then tell the prescribing physician. Diamox can help lower the pressure a little bit. Cosap and Lumigan can help lower the pressure. LPI is fortunately not going to work because this is not pupil block. This is a secondary angle closure without pupil block. LPI only works with pupil block. And before this mechanism was identified, there are a lot of people that got LPIs that it just didn't work. So really the best thing to do, a cycloplegic such as atropine and a topical steroid such as Predforte or difluprednate. You can use a Diamox, you can use a topical medicine to bring down the pressure, but really putting that uveal tissue at rest is going to be the best thing to do. How long does the in-office treatment take to work? How long after discontinuing the medicine will the effect be there? Well, it does resolve really pretty quickly. If you stop the medicine, put them on an aqueous suppressant, a steroid, and a cycloplegic, it's going to resolve pretty quickly. Now, here's the caveat. The myopia tends to take a little longer. That could take several weeks, but the pressure will come down pretty easily. I think that might be it, Greg, or is there another? Okay, so plan to stop the Topamax, add a steroid hourly. At the time we had scopolamine and a beta blocker twice a day. And really within a day or two, she was a whole lot better. The myopia was a little slow to go away, but the rest of it resolved pretty quickly. Next one, Greg. And as you can see at the initial presentation, how shallow she was. But when we start putting her on the cycloplegic and the steroid, it's gonna stabilize the vascular membrane, reduce the leakage. And there's no LPI here. She just really opened up in the next day or so. Pressure came down nicely, but again, for some reason, the myopia took a little while to go away.
Yeah, that's kind of been my experience, Joe. It could be up to 3 or 4 months for that myopia to kind of get back to where it needs to.
Now, the three most important things to be aware of: 1, there's a medicine that's precipitating. 2, it's not Iris Bombay, it's a flat chamber. And 3, it is bilateral, or typically bilateral, whereas most cases of primary angle closure are unilateral. And this is not anything that builds up. I remember, working with a colleague in the university who had a patient in Topamax, and my colleague said, "I've got this patient. I'm going to do gonioscopy every 3 months, and as soon as I start to see it shell, I'm going to get an LPI done." And I said, "Well, that's great, but it's not correct." So, not pupil block. It's not going to be building up. It doesn't go slow. It usually happens right away. And I think that's it, Greg.
Yeah. So, just kind of keeping the theme of toxic optic neuropathies here, you can see that we have a list of medications here and other causes, as in, heavy metals, fumes, solvents, alcohol abuse. Over here, we kind of have some different medications that are out there. And I think Joe kind of summed it up nicely, and Joe probably won't say it, so I'll have you say it. But if it's bilateral, vision loss, we got to think, what did you say? Nutritional, toxic, and was there a third one we need to think of?
Mitochondrial.
Yeah, the mitochondria side. Yep, thank you.
What you have here, what you have on the slide here, Greg, what I want to tell the audience is really, number one, the ethambutol. If you see that, my recommendation is get a baseline field, get a baseline photograph, and get a baseline OCT. And
let's jump into ethambutol. So with ethambutol, still being used in the fourth drug treatment for a patient that has, active Mycobacterium tuberculosis, what we know is TB, that's out there. I can tell you 2 cases in 2019. And again, that kind of has been kind of along the way. 1 or 2 cases a year, patients coming in with ethambutol toxicity. This is an 81-year-old woman. She calls the office reporting decreased vision. This was on March 13th, 2019. She was warned. This is a fun case because this is a patient of mine that is a glaucoma patient. She's doing visual fields all the time. She gets vision loss. She gets visual fields. She's using it for Mycobacterium avium. I had to look that up. I certainly didn't know what that was. It's kind of like a low grade, like lung infection. To me, it's kind of like, blepharitis of the eyelids. It doesn't really, blind you, but it's more of a nuisance. And that's kind of what this Mycobacterium avium is of the lungs. So you could see here erythromycin, rifampin, and then ethambutol. And that was started in 2017. She's been doing visual fields, once a year, twice a year for glaucoma. She's been warned on it. She's on latanoprost, Rhopressa. She had a KDB on Cahook dual blade for her glaucoma. It's a mixed procedure. She's not currently on any drops, but obviously she has glaucoma and we're following her. So she comes in on March 13th here, 2019, and her visual acuities 20/30, 20/20 or 2100 right and left eyes, 20/25 together. And she's going, "Yeah, doc, I think I'm dimming like you told me." And I'm like, "Okay, we'll get the visual field." And if you look, she's like, she's 20%. And she's 20%, and she's got a -22 and a -21 on the mean deviation. You could see the overall just decrease. And I'm like, I warned her and I told her, and she gets it. So the cool thing that I've noticed with these patients, you got to warn them and tell them, but they don't come in. That visual field needs to be at about 20%, before they come in. And you can see what has happened with her being on this ethambutol. So I called the infectious disease doc up, or the doc that was prescribing this. And I said, "Okay, here's the visual fields. I'm going to send them over to you. This is what I think it's from. I think we should just discontinue the medication. I guess, maybe do some MRI testing, whatever else needs to be done." I didn't work her up. We just thought it was this. Then we'll have Joe weigh in here on this towards the end here and see if anything else needs to be done kind of neuro-wise. But, we made the right decision because you can see here, luckily, that's why I like presenting this case. Here she is, March 13th. Here she is about 5 weeks later, and her visual field is starting to come back. Here's her 37%, and she's up to 55%. And then over the course, she was able to get back to 20/20 vision in 2025. And check this out. She's now back to her kind of in this left eye, her original glaucoma defect, and kind of glaucoma in the right eye here, where we were following her. She's back to this 91%. and 78%. So this is one here that, that was lucky. We showed you Amiodarone that didn't return. This is one in a sense is reversal. I saw her recently. This is not in your handouts if you're looking for it. I remembered this case and I was presenting it. She was just in May, so we took some optic nerve head photos. You could see that they're glaucomatous, but Joe, is there anything here, neuro, that you want to point out? I know you've never seen these, so I'm, kind of throwing you under the bus here, give you a little chance to take a look at them, but definitely glaucomatous. But anything from the toxicity side here?
The rims are so thin, it's hard to gauge pallor, and these are not really your true disc photographs. And I do like disc photographs, and you really need to have disc photographs, OCT, and visual fields on these patients. Bill, it mentions how do you follow these patients, because he's seen these go from 0 to 60 in no time, in no time flat. And I think we probably should be seeing them every 3 to 4 months, and looking for disc pallor, looking for any sort of change. Because you're very lucky on this one, because once you get into toxicity, it may not recover. So I would be looking for disc pallor, because that's not a feature of glaucoma. I mean, it certainly is not. The rim tissue is very thin. But in a case like this, I would recommend MRI of the brain orbits and chiasm. I would also, right now this looks all glaucomatous. We go back to the original visual fields. You've got to be looking for compression. You have to look for a number of things, but at this point we've got to consider toxicity. Heavy metal screening, I'd probably recommend as well.
So there's her optic nerve. Thanks, Joe. Here's her optic nerves on May 9th. And then I added these today because the last time that she was in and couldn't get my scanner to work. So I apologize. Basically took pictures with my cell phone and sent them over and plugged them in here. But here she is, the last visual field for glaucoma. She's back up to 92%, and 85 here is more of a kind of a glaucomatous defect. You can see she's 84 years old, and this is back on, November 8th of 21. I guess I got to fix that. That's a little typo. This is November 8th, not November 21st here. I got it right here, November 8th. But this is what I think this was really fun. If you just kind of look at this progression here, we can see here as we go across, this is all glaucoma. This is just a bad visual field that she took that day. I don't know what happened, so just ignore that. But you can see glaucoma, 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 glaucoma. Then we kind of lost her for a little bit of a visual field. And then she comes in with this, hey, doc, this is what I think you're talking about. Look where she is. I mean, maybe this was a glaucoma visual field here, but then look, she comes back 2 months later, and they do go down quick. Boom. But then I followed her, and you can see what happened. And you can see this is her last visual field here on November 8th right here. So there's November 8th. So this is kind of cool. Check this out. Boom. But then what I want to point out too is don't forget that this glaucoma progression analysis is taking in all this. So probably at some point, I'm just going to re-baseline her here and then take the glaucoma progression analysis. That's her left eye. You can see the right eye, similar thing here coming across. Boom. Look at the quick drop down. And then you can see how I followed her. And then just again on November 8th here, right here, November 8th, you can see this is her glaucomatous defect. So here she is back in 2005. Here she is in 2008. We're doing pretty good over all those years, despite getting a toxic optic neuropathy. Just a fun case that's out there with lots of moving parts between the glaucoma and the toxic optic neuropathy. Any comments on that, Joe, before I move on into some other toxicities?
No, that was a case where the outcome was very fortunate, because once you start, poisoning the optic nerve, you often don't recover. Also, you have a patient who has prolonged and profound disc edema. You'll start to lose vision. That will become atrophic. So, there is a certain amount of time involved on these cases, and certainly a fair amount of good fortune as well.
I don't think this one's in your handout. I apologize. I think this part is, I just added a few other slides. So Dupixent is an injection. This is really just from their website. It's used for atopic dermatitis. I can tell you the commercials kind of match what the patients are. You know, they come in talking about their atopic dermatitis, how they able to take their shirts off and be able to not, in a sense, be embarrassed, so on and so forth. It's used for asthma, chronic rhinosinusitis and nasal polyposis. And it's also, you could see here, for eosinophilic esophagitis. And a lot of times we see it used for this atopic dermatitis. And I can tell you the patients really, really like it. Just going right to their websites, going off of warnings and precaution. This is one of many that is listed, just like any other biologic. Dupixent, as you can see here at the MAB at the very end, stands for monoclonal antibody. So it's going in and tinkering with the immune system, and that immune system doesn't like to be tinkered with. But one of them is conjunctivitis and keratitis. And I believe this is in your handout, so you can go through and read right what they have in their warnings and precaution. And here is a patient of mine who comes in, and she does have this atopic dermatitis, and she loves her medication, to how it's cleared up her skin, despite the inflammation and the dermatitis that it is creating around her eyelids, along with the conjunctivitis. It's kind of neat that we're using this to clear up an atopic condition. But if you can kind of keep them on it, use some steroids. I can tell you what I've been doing for these are pretty recent cases here, the two that I'm going to show you. And what I've used instead of steroids on these cases is I've used Regenerize. It's a new kind of, naturopathic, kind of amniotic membrane-ish, for lack of a better term, but in a bottle. Here, she's not really having any eyelashes, and I should zoom in, but she's starting to get some eyelashes back. But I used another biologic, a natural biologic. This is Dupixent, a allopathic biologic, and we have Regenerize kind of taking care of the conjunctivitis that's down here. So here she is, dosing info for Regenerize, spelling. You got it pretty close there. REGEN and then eyes, EYES, Regenerize. It's a natural biologic agent, kind of that amniotic membrane / fluid. It's acellular, getting all those anti-inflammatory kind of cytokines that are out there used to treat. And you got to be careful. It comes in like 3 milliliter bottles. So they have a pro version, a light version. I usually have them start off with about 4 drops a day and kind of quickly wean it down, because they can run out of it pretty quickly, but it works really, really well. So that's this patient here. Same patient here, just different angles. You can just kind of see all the redness. In this one here, she's able to get her eye open. You can see the conjunctivitis. Look how red and swollen these lid margins are, kind of this little ulceration. But you can see over time, we were able to, 1, with her adapting to the medication, and 2, by using the Regenerize that's out there. We have Dupixent, another case here. I tried getting the follow-up photos. I had my patient see if I was going to try, while Joe was talking, maybe stream them to my computer here. But this is a gentleman, again, he's on Dupixent. Again, loves it. Loves how his skin is clearing up. You can see the redness. You could see kind of this, say, follicular type of reaction. You can see the injection that's going on with the patient. I flipped his eyelid. You can see the injection that's going on, this kind of, if you want to say, maybe in this case, kind of like papillae type reaction going on with him. Here's a video here that I have in the office of him. And you can see here, as I'm playing, I'm just pulling down the lid and just showing you kind of that type of allergic reaction that's going on. He does have some dry eye, I believe. I think there's a plug in place there I saw. He's got an autoimmune condition, usually dry eye, younger guy here. Again, loving how his skin is clearing up. Doc, I don't really want to stop it. Can you help me with this? And so we put him on some, again, Regenerize. Again, I have no financial benefit by saying that, just telling you what I did for him. Here I am flipping his lid and zooming in there, kind of showing you this kind of the same pictures, but what it looks like kind of live and with videotaping it. With that being said, I'm going to see if I can hold this up here and show you guys that if I can just kind of show you, I'll see it up on the screen there. That's his eye. I'll get these inserted. That's before and after. He sent me some other pictures here. Here he is here showing me his conjunctivis. So I texted him today and he was able to take these with his cell phone. You can see how that has cleared it up. So since then, I've seen some other cases. I didn't think we needed to see any more than 2 cases, but that's what Dupixent can create, that conjunctivitis, that keratitis, that kind of dermatitis to the skin. I don't usually stop it. I let their docs know that it's going on, who's ever doing the injection. And it's usually a rheumatologist. And then I just try and treat them with steroids, but then that has a side effects. These people are usually younger. There's steroid induced glaucomas or ocular hypertensions. And then, so I've been using something more naturopathic, and this has been working really well. Let's see. I see a whole bunch of questions rolling in here. So let's see, how far back do I gotta go? Regenerize. Will Regenerize be for lifelong for her? Sorry for the questions. I have a super atopic dermatitis. I'm not sure. You know, the patients actually love this medication. They have dry eye. It goes after all the interleukin 2, 6 is the big one, right? Interleukin, anytime you see interleukin 6, that's kind of like the orchestra, the conductor of the orchestra. But 2, 4, 6, 8, all those interleukins that are pro-inflammatory. Patients really, really like this. It helps with their dry eye. That's out there. So how long will they be on it? They love it because it helps with many things along with clearing up this conjunctivitis. So how long after the medication discontinue will this persist? I haven't discontinued any of this. These patients love this Dupixent. It changes their lifestyle, it clears up their skin. They feel good. They kind of adjust to the medication. I just kind of use something to help them topically along the way to get there. I haven't had to discontinue any Dupixents to this point. I'm sure as I get more ends, that might change. Again, what is the dosage for Regenerize? You know, I start them off maybe every 2 hours, 4 times a day. It is only a 3 milliliter bottle. The cost is pretty fixed. You can look at it up on the website. So I try and use it really cautiously because again, because it's about a 3 milliliter bottle. What is naturopathic steroid and dosage? What is a naturopathic steroid? I don't know of any naturopathic steroids. Steroids would be more allopathic. That's generated by the pharmacy. Naturopathic would be, in a sense, if you want to say using, you know, if you want to say alternative or something that's found in nature, naturopathic, which would be vitamins and amniotic membranes and Regenerize and hypochlorous acid. We all do it. We're all integrative optometrists to some extent because we probably recommended AREDS to someone or EPA, DHA. Remember, that's not allopathic. That's kind of naturopathic in a way. And that's what this medication is there, Peter. All right. I think I'm caught up on that. And it looks like I got getting close here to we're just going to get we're kind of in cruising altitude here. And we're kind of putting our tray tables up and getting our seat backs up to start landing here. But let me run through a couple more medications so we can land on time here. Osteoporosis medications, Fosamax. You know, we see these from time to time, creating a conjunctivitis. It's more of an episcleritis. Seems to happen about the first, you know, couple of weeks of the medication. It's one of those as the body starts adjusting. So Fosamax I see it more as an episcleritis, but it's been reported uveitis, keratitis, iritis, all these itises. I see it more of kind of an episcleritis that's out there. And every time I do this lecture, and even I just gave this lecture on Sunday, I have a couple cases and I forgot to put them in here. But the COX-2 inhibitors are still out there in a sense as Celebrex. And they've been talked about with cataracts, glaucoma, conjunctival hemorrhages, and floaters. We really don't see the Vioxx and Bextra anymore because of the cardiac issues. But when I do this lecture with Tracy, she still has a handful of patients that are still taking Celebrex. So just be aware of these ocular side effects. When it comes to the anticonvulsants, I asked Tracy one time, I said, is it truly a black box that pops up? And she goes, yeah, it's truly a black box. When you type this medication in, Sabril here, it literally pops up on the screen like this for a pharmacist. So when they talk about a black box, here it is. Here's the black box warning. And they literally have to read all this, make sure the patient understands, and they have to, in a sense, sign off electronically or type their initials in there that it was given to the patient. So when you see this medication, it can cause optic atrophy, optic neuritis, peripheral constriction of the visual field, and decreased visual acuity. That was on that list, if you remember, when I had that list up of toxic optic neuropathies that's out there. So we thought that this was worth bringing to the attention that's out there. And again, Tracy goes over this and she talks about the medication. So I just kind of left this in there, left it in the handout to be reviewed for you whatever time. And so it's a toxic optic neuropathy. It's selective, irreversible inhibitor of the GABA transminase, and it's just not used that often. It's usually used in infants that's out there, or the younger population, but just worth being aware that it can happen. And let me go through these real quick. We have the autoimmune agents, Gilenya. This is not used that much, but we had macular edema for the fingolimod-associated macular edema. I'll go through this case pretty quickly because I want to hit the highlights of the Plaquenil case. So this, was a patient of someone had MS, was taking a biologic, was switched to fingolimod, and the visual acuity dropped. And you can see here the macular edema that was created, which is the fingolimod-associated macular edema that's out there. So, prior to starting the medication, you want to get an OCT for these. Again, it's not used that often, but worth, noting that this medication plus other medications out there, this is where we find some of these side effects from these medications, and that's why we have to report it. Dr. Joe Shovlin was attending one of the lectures, and he was nice enough to share this fingolimod edema case. And after they stopped the medication, you can see that it returned back to normal.
Hey, Greg?
Yes.
You can thank him personally. He's on the webinar.
Okay. Yeah, I texted him today to see if he was going to be on it. And thanks, Joe, for submitting that case for me. That's out there. I'm not going to do the polling question here, Joe, to save some time. I just was curious whether or not you've seen Plaquenil toxicity. Dr. Shovlin has shared a case. If you see this Plaquenil toxicity, this kind of bullseye appearance, you can see here that the horse is already out of the barn. But I want to point out that it's not a foveal disease. Remember, the macula is 2 disc diameters. So if this is the foveola, macula is 2 disc diameters. The whole macula is this area here, not that little fovea where most people think it is. This is the fovea. This is the parafoveal, perifovea. So this is kind of a perifoveal type of disease. The fovea is kind of spared for whatever reason. And what happens with Plaquenil toxicity, you need a B scan OCT, not an OCTA. That's better for macular degeneration and diabetes. The B scan is the one that we typically have in our office that we've had around since the 2000s. And you want to make sure you're kind of looking in that perifoveal. Now, we still use Plaquenil quite a bit in our disease modifying anti-rheumatic diseases, right? So, your rheumatoid arthritis, your Sjogren's patient, even though biologics are, become a big player, they still have multiple side effects and monkeying around with that immune system. So Plaquenil is still used, that's out there. So it's still used as an anti-inflammatory. We had guidelines since 2002. Then there was guidelines in 2011, and then they revised them in 2016. I'm going to tell you right now, as I don't subscribe to that. You wait 1,000 grams takes 5 to 7 years, because I've learned that there is bio individuality out there. I work right down the street from a 6-man woman rheumatology practice, and they sent a lot of their cases over. I picked up Plaquenil toxicity in patients after being on 2 to 3 years. That's out there. So I image them and I follow them yearly, and I use an OCT. I do visual fields, but you're going to pick up early Plaquenil toxicity with an OCT. That's out there. These are Larry Alexander's slides. He passed away suddenly, probably about 5 or 6 years ago. He was just highlighting here that the disease is in that pair E foveal zone. And what happens is when you get this dropout going down, there's atrophy basically in this outer retina, because the Plaquenil builds up in the RPE, and it creates a toxicity basically to the outer retina. The outer retina atrophies, and these parafoveal, where the ganglion cell humps are, if you want to say, start to drop, which makes this look like it's going up. And they call this flying saucer effect. Kind of what you're seeing here is this is coming down, and you got this kind of flying saucer or top hat effect. So here's some advanced cases down here. If you follow the outer nuclear, I'm always following the outer nuclear layer, seeing what's happening. And you can just see where is it going here. It doesn't really pick back up until out here. And then we have some kind of issues maybe going on here, but you could see the atrophy in this patient here. We could catch it a lot earlier. Here again, the photoreceptor integrity line, which is nothing more than the mitochondria, the photoreceptors. We've got the outer nuclear layer, and all of a sudden just comes crashing down from this Plaquenil toxicity. But you can see here in this case that kind of that foveola area is still preserved. But look how flat this is. See how flat this is? Look how curvature. If I wanted a sled ride, I want to sled ride down this hill. If I want to ski, I want to slide down this hill. This is kind of a boring hill right here to go skiing and sled riding down. So let me show you and wrap you up this case of a 71-year-old woman with lupus, hypertension. You can see taking the classic dose for 15 years. I saw her in 2013. She comes back in 2016. She saw the primary care doc after I told her, and the rheumatologist. The primary care doc said, "Hey, Greg's just an optometrist. Go see the ophthalmologist." Ophthalmologist said, "I know Greg's pretty decent at this stuff, but I don't see it." She gets sick and tired of waiting there. So she comes back to me in 2016. What I'm showing here is luckily she doesn't have that horse out of the barn. I don't see that bullseye here. I don't see really much showing up here at the RPE level. But let me show you what I saw in 2013. You can see right here, this right here is where I'm cutting through. It's kind of hard to see the atrophy in this area. So I want to cut down to this level. Watch what happens with this line. See how this line's coming down right here? And I'm going to get to this level right here. This is the line right here. And if you come across and follow this nuclear level, this nuclear line, why is it getting thin right here? Yeah, because there's some toxicity going on. If you follow it across here, like why is it getting, a little boggy here, a little bit of atrophy going on? You can see here that it's thin in this area. So she comes back 3 years later. You can see 2013, 2016. Look, she's changed 18 microns in this area, 16 microns in this area. But take a look at this. Look right here. Look at this hill. Wouldn't you want to sled ride or ski down this hill if you're a sled rider or a skier? Look how fun this hill is. What happened to the hills here? They're flat. It's the same cut, but look what's happened to this nuclear line right here. Look how this has become foggy. See how this looks like a flying saucer, that top hat? This has come down, this has come up, but look at this toxicity that's out here. It's a little bit easier actually to see on the left eye. It's pretty obvious on the right eye. Again, follow the nuclear layer through. Where's the nuclear layer here? Yeah, there's toxicity. Follow this nuclear layer through here. Where's that nuclear layer? That's toxicity. But, hey, you can watch it. You can see what happened. 21 microns, 19 microns, and follow the nuclear layer here. Pretty obvious. Look at this hill, the sled ride down. Look at this hill, the sled ride down. I'm actually working with OptiView to see if they can actually, because when I draw these on the screen, like right on my Optomap, just try to get the drawing feature and take this and put them side by side. You can see the change. So I think that would be a nice metric to have. But you can see the atrophy here and the atrophy here. So that's how you look for Plaquenil toxicity on these patients. Again, Joe, thanks for being here. This is a pretty obvious Plaquenil toxicity. Follow this nuclear line right here, this outer nuclear body, and comes crashing right down to the RPE. You can see all the outer retina is atrophied. So Joe, thanks for sending these. You can see here he's using a raster scan. A lot of people ask what scan to use. I recommend raster, and you can see the crashing down. You can see the crashing down here of this patient, and another patient here by Dr. Joe Shovlin, who is one of the past presidents of the American Academy of Optometry. Joe, thanks for serving at that position. And you can see here going across, come crashing down, some Plaquenil toxicity. Here are the visual fields that Dr. Shovlin was nice enough to share. You can see kind of that paracentral visual field defect, and that's a 10-2, and that's a 10-2 on this patient. So we want to try and catch them. So the last polling question, Joe, as I look, if you can put that on there, is, some of these adverse drug reactions were new to me and will help me in patient care, because that's the end. And I'm going to look at the polling questions as that rolls in. Are these side effects permanent? If you're asking about Plaquenil, they are. And if you discontinue the Plaquenil, my analogy is if I'm driving down the road and I take my foot off the gas, and I'm going 60 miles an hour, my car eventually will come to a stop. So even though you stop it on June 14th, you'll probably still see changes for 6 to 12 months, because the half-life of this medication is pretty high. I want to say months. I wish Tracy was here to answer that, but the effects are permanent, and they can continue even beyond, a year or two as that medication clears out of the system and things progress. What follow-up is recommended for methotrexate? I'd have to look to see what methotrexate is. I really don't have much of a big ocular side effect that's out there with methotrexate. What do you look for on the OCT? I just showed you that, if that's what you're looking for. And when you think you see mild toxicity, do you report to the prescribing doc right away or keep watching? That's a great question. That's what I'll wrap up with. I just had someone come in the other day, 94 years old, with early toxicity. I called up the rheumatologist and I said, look, she's 94 years old. She doesn't need to be on any biologics. It's very early. I'll monitor her. So that's a case where we're not going to recommend discontinuing. I can do observation and monitor. But, I had a patient just recently, I didn't put it in, that she was 67 years old with early toxicity. That's someone we're going to stop. I'm really not going to monitor. She's in pretty good health other than some autoimmune conditions. And so that was one that we made a recommendation. So they don't always have to stop the medication. You can monitor, but based on age, and now that there's other types of medications that are out there, you don't have to I would recommend discontinuing, because there are other options. So, but you don't have to stop them like in my 97-year-old. So with that being said, I see the thanks rolling in. Joe, what was the results? Is it
98% said they got something very helpful they didn't know.
Perfect. Awesome.
And probably the other 2% was Joe Shovlin.
Yeah, that's true. Hard to teach Joe something. He's a brilliant guy. So with that said, thanks everyone for attending. I got the questions earlier. So this was complications of pharmaceuticals every optometrist should know.